Very important and very moving meeting. So I am Laura Seeff. I'm one of the Associate Directors in the Division of Cancer Prevention and Control at CDC, and I'm going to be talking for the next 15 minutes, I hope, on designing community-based programs, interim results from 5 federally funded screening demonstration sites. So let me just first touch on a few statistics on the U.S. population and U.S. healthcare. You heard a little bit of this from Carrie. So in the United States, there's roughly 300 million people from based on 2007 data, 13% of whom are in poverty, 16% of whom are without health insurance. And this is actually the population that we at CDC serve, the low-income and uninsured population. In the U.S., as opposed to a lot of the countries represented here, we have no true national healthcare system. And those who are insured get a mix of private and some public insurance. There are a few publicly funded insurance programs that Carrie just touched on a few of them. And here are 3 of the main ones. The S-CHIP program, which was in the news quite a bit last fall. One of the first things that Obama did was expand this program. This is a program that provides health insurance for low-income children. And then Medicaid provides insurance for low-income individuals and families. But up to 60% of people in this country who are low-income don't qualify for Medicaid. And then Medicare, which Carrie talked about, which is for people 65 and older, regardless of insurance. And these are funded through the U.S. Department of Health and Human Services, which is made up of 11 agencies, one of which is mine, CDC, as well as federal FDA, Indian Health Service, NIH. So CDC, where I am, focuses on public health in the U.S., uses federal funds for public health. And my division, the Division of Cancer Prevention and Control, focuses on cancer control. And we have a budget of about $300 million, which boils down to about $1 a day for public health cancer control in the U.S., which is not much. And this list represents our investments in cancer control. So our biggest investment is in organized cancer programs. Our longstanding program is our breast and cervical cancer program, which I will touch on shortly. And again, this is for low-income, uninsured, and underinsured individuals less than 65, so before they hit Medicare. And all of these programs are supported in cooperative agreement with states, tribes, and territories in the U.S. So it's a federal-state relationship. We also support several other activities, and I'm going to touch on these because they are all integrated with our screening programs. We support the National Program of Cancer Registries, the National Comprehensive Cancer Control Program. We have a busy applied translational research portfolio that I'm not going to touch on today. We have many active partnerships, many of whom we fund, and support several education and awareness programs, one of which you've seen from Katie, and I'll show you some examples of that. So this map represents national cancer surveillance in the U.S. There are now cancer registries in all 50 states, in the District of Columbia, and in 2 territories in the U.S. And these programs are funded by CDC. The green programs are funded by CDC, and the yellow programs are funded by NCI, the SEER program, which is a long-standing program. And together, between CDC and NCI, we now actually capture all cancer diagnoses in the U.S., which for a country that has no national healthcare system has been quite a challenge, or quite an achievement, rather, and a challenge. And these data are reported in multiple venues, but they are published every year in the annual report to the nation. And this is the cover of last year's report, which documented a decline in U.S. cancer incidence and had a special focus on tobacco-related cancers. And this year's report, which will be due out in the summer, more likely fall, will focus on colorectal cancer. CDC has also assisted every state, every U.S. state, and a number of tribes and territories in establishing comprehensive and coordinated cancer plans. And all of those have identified colorectal cancer control as a priority. And then this is one of our long-standing public awareness campaigns, which was launched in 1999, and it's made up of fact sheets, brochures, and TV and radio PSAs, all of the materials available for free, actually, on our CDC website. And about 5 years ago, we began partnering with Katie, and this is the diorama that she actually mentioned. And we also, every year, put together new materials, usually using some actors, and we've recently put together a very powerful series with Terrence Howard, who actually just lost his mother to colorectal cancer. So this is our National Breast and Cervical Cancer Early Detection Program. This began in 1991 through a congressional mandate. So a law was passed to establish this program. It started small, and over the ensuing years up until last year, it's now spread across the entire country and is in 5 U.S. territories and in 12 tribal areas. And because each of these entities has its own unique personality and a slightly different health delivery system, this really effectively represents 68 different health delivery systems. And again, these programs are supported by CDC in collaboration with each of these sites. But there are obviously standard features across all of them, so they all use our money as well as some of their own money to provide screening, diagnostic services, patient support, data collection, et cetera. There are quality measures in each of these programs. And of note, when this program, the breast and cervical program, started in 1991, there were not systematic resources for treatment, so there were no federal funds for treatment. So each of these programs had to identify local or sometimes state resources for women that were diagnosed with breast and cervical in these programs. And then a subsequent law was passed a few years ago, which now waives the women diagnosed under our program into the Medicaid program to pay for their treatment. So given the history of our longstanding history with the breast and cervical cancer program, and anticipating that we would be mandated to establish a colorectal cancer screening program at CDC, we established a demonstration program a few years ago so we could influence as best as possible what that program might look like and learn about how best to roll such a program out. So we set up this program with these purposes: to support screening in response to sound science, potential to save lives, and interest from states, because again, that's who typically we work with, U.S. states. To tailor these programs to communities, so you'll see that they vary and they reflect the communities where they exist. To explore various screening models, including our breast and cervical program, but not limited to. And then the overarching question was, is it feasible to establish an organized program for an uninsured and low-income population for colorectal cancer? So these are the sites that were selected, and I neglected to mention that with our breast and cervical programs, with all of our programs actually, these are competitively funded, so states need to apply to us and are competitively selected. And this is who we funded in 2005, and this program is actually winding down this fall. We had many more applications than we could afford. And these vary in geographic reach, so there's county-based, city-based, and state-based programs. There's a program on Long Island here in New York, 2 city-based programs in Maryland and Missouri. We have 1 single state, full state program in the heart of the U.S. in Nebraska, and then a 3-county program in Washington State. And each of these programs vary on what demographic subgroup they reach out to, and we also allow them choice of tests as long as they selected a test that was U.S. Preventive Services recommended. And I'm not going to go into the details of which they picked in the interest of time. And the components of that demonstration program look a lot like our breast and cervical cancer program, with the exception that we're back where we started with that breast and cervical program and don't have federal funds for treatment. So in this demonstration program, again, the sites we selected had to come to the table identifying local resources for treatment. And this is something there's a lot of attention being paid to, and I think will change in the future, hopefully. So along with supporting the screening program, we also conducted an in-depth 3-pronged evaluation of this demonstration program. So qualitatively, what do these programs look like? What were facilitators and challenges? We've been collecting screening data so we could measure patient outcomes and screening quality. And then we've been measuring cost of the program, both all the program components, and Michael talked about that not being included in some of these models, so the program components as well as the clinical components. And all the tools we used actually to do this evaluation are also available on our website. So here are some midpoint program results after 2 years. On the qualitative side, what did we learn from the startup period? And it took these programs on average 9 to 11 months to get up and running. And some of these facilitators and challenges have been touched on in several of the presentations today. So a key facilitator was building these colorectal programs on something else, and that something else varied across the 5, but it could have been a breast and cervical cancer program There's a university-based program here in New York on Long Island, but building on something facilitated establishment. Partnerships were very critical. The American Cancer Society was a key partner, and our comprehensive cancer control program. Having clinical expertise was critical at program development and during implementation. And remember, these are public health departments who typically may not have a physician or even really a standing relationship with a physician. And then having a program champion, and that's been talked about, so a local Katie Couric type person to really wave the torch and carry the water and keep people focused on this was a huge facilitator. There were administrative barriers. Contracting endoscopists was a challenge, and again, lots of endoscopists in this country don't have anything to do with public health and health departments. And some of the endoscopists were particularly concerned about the lack of federal funding for treatment. And then in general, resources were limited. So these programs got on average $500,000 to $750,000 a year, which is, when you're rolling out a program, is not a lot of money. Since implementation began, we feel that feasibility was established. We did stand up these 5 programs. Multiple models were effective. So again, this is in part a reflection of the U.S. healthcare system, but leaving personality and differences by state has been effective. We intended to reach an unscreened population, which you'll see in our screening data we have been. Again, this has been touched on quite a bit today. Men have been more difficult to reach. In part, again, because some of them are built on our breast and cervical cancer programs, but men typically, as we've talked about quite a bit, access preventive care much less. And then in-reach wasn't always sufficient, so where programs did build on a pre-existing program and hoped to reach into their pool of patients, that was not always successful, particularly when they were hoping to reach into the women enrolled to get their men to come in. That wasn't always successful. Some implementation findings on the clinical side, having a medical home, and I use that term broadly, but somewhere to draw patients out of and send them back to, and then having patient navigation, so someone to walk these somewhat disenfranchised population through the screening cycle was very important. We've seen a change in test selection over time, so one of our programs switched from primary FOBT to colonoscopy. Another of our programs now offers a choice. Our clinical complications have been very low. There have only been 2 perforations. As for screening, we've been watching our FOBT return rates, which were lower than we'd like, but are coming up. And we have found, and we touched on this as well, that program integration was very effective, rather than establishing a silo colorectal program. So here's some screening data, and these are mix and match programs. So again, it's county, city, state. Numbers are still, and this is not generalizable or representative of the whole U.S. by any means. But we see, screening started low, but it continues to increase. And here's who we're reaching by gender and by race and ethnicity. So again, you can see the vast majority are women, and this is not by design. And about half of our population is non-white Hispanic. And we typically do reach out particularly to minority groups. By age and by risk factor, we set up this program primarily to reach people, again, under 65 and at average risk for colorectal cancer, and you can see that is who is coming in. And again, we hoped to reach an previously unscreened population, and you can see 2/3 of the people coming through our program had not been previously screened. You holding up the yellow card for me? Thank you. So I will go quickly at this point. So comparing who we're reaching, this is just who we've screened, not by outcome. Colonoscopy programs versus FOBT programs. We seem to be able to reach more people more quickly with FOBT programs, but we have not yet married that with our data to show are we actually finding more outcomes in FOBT programs. We're waiting for more data to accumulate. As for FOBT return rate, I touched on this already. Of the FOBTs we've distributed, one concern is half of them don't come back at all. Of those that do come back, we've seen a 10% positivity rate, which is a little bit higher than you see in clinical trials, maybe a function of our patient population. And then of those who had a positive FOBT, this is the cascade of having had them follow through colonoscopy to findings. 158 of them went through colonoscopy. There's some number that are still pending. And then you can see listed here the low-grade dysplasias, high-grade dysplasias, and how many invasive cancers from a screening FOBT. For those screened with colonoscopy, this is the breakdown of how many were normal, how many low-grade and high-grade dysplasias and invasive cancers. And these polyps are not hyperplastic. That's lumped into normals. And this is how many we've reached all told across all 5 programs. And the majority of those we've screened have been negative. So quickly, we've also measured very carefully cost, both in the startup period and the implementation period, clinical costs, and then when we're done with the program, we will cost out the few complications we've seen. And this slide here from both the startup and implementation phase shows the take-home point here is that these programs had to rely on in-kind resources as well as money from us. And then in the startup phase versus implementation, this is by program category. Unfortunately, these 2 bars look like they're the same color, but on the startup period, most of the money went towards program management, and then since implementation, most of the money has gone towards screening, as you would imagine. And at the end of this program, and we'll gather our last data this December, and we'll do all our final evaluation, we'll be able to marry our cost evaluation, for instance, with our clinical data to see what we can learn. We'll be able to see changes in screening rate, outcomes by test type and program design, cost per person screened, and then where are the costs and cost efficiencies. And we're actually simultaneously also modeling these types of data that will be national. So as we've been looking towards this program winding down, we've been busy planning what comes next and spent all of last year engaged in a series of stakeholder meetings with our key partners, state health departments, our sister health agencies, outside experts, cancer community advocates, and we've been assessing need and interest from states, and there really is an expectation from states that the feds remain in the field supporting screening. And then we've applied what we've learned to define what comes next. And we are now in the process, actually, of, this is my last slide, of looking at applications for our next program. And we have received $25 million to expand what we did, and we'll be selecting 18 to 20 programs to continue to support colorectal cancer screening for low-income, underinsured and uninsured men and women. And critically, and we learned this from our demonstration program, these will be integrated into something else. It could be breast and cervical cancer screening programs or some other chronic disease effort. And I will close with pointing you to some resources on our website. Thank you very much.